So this was crude incidence rate of first GI bleeding hospitalization. Just I illustrated the incidence rate by kidney function and periods with and without SSRI. And obviously you can see periods with SSRI is higher than periods without SSRI. And this is increasing every kidney function decline. So I wanted to discuss based on this result that, and also this is a difference between periods with and without SSRI. And I wanted to discuss this is increasing so that SSRI is not recommended in patients with lower kidney function. But my supervisor came again, and these differences are unadjusted and influenced by confounding factors. And adjusted analysis are needed. So by which she meant that, for example, this period and that period are quite different because other confounding factors such as aspirin or anti-acid drugs may be different. Also diabetes status may be different. So these are indeed confounded. But I was confused because when we usually do statistical analysis or adjusted analysis, it's logistic regression analysis or Poisson or Cox regression analysis to estimate relative risk. But what is risk difference adjusted for confounding factors? And after learning for a while, in RCTs, treatment group and control group are well balanced because of randomization. And you just take a difference between the groups, which is crude. But this is treatment effect because there is no confounding between the groups. But in observational studies, if you take the difference between the group, this is unadjusted, but these are confounded. So confounding adjustment is needed to estimate treatment effect. This was very new to me. And I consulted statisticians, and he suggested 4 or 5 options. And the first is the easiest one, probably. Hazard ratio or rate ratio multiplied by absolute risk in control group. But this may be a bit different from true effect bias because of proportional hazard assumption. This is a kind of rough estimate. So the statistician didn't recommend me to use this method. And the second option may be crude risk difference between propensity score matched two groups. Because propensity score matched groups are equally balanced. So that if you just take difference, this is a kind of adjusted by propensity score. But in this study, my study, this was not useful because to use propensity score matching, you have to calculate propensity score at one time, single point. But in my study, one patient could have both periods with and without SSRI. So calculating propensity score every time for individual patients was difficult, so not realistic. So this was available to me. And the rest were additive Poisson regression model and marginal structure model. This is quite statistically difficult. But after discussing with the statistician, I decided to use additive Poisson regression model this time because I thought that it's relatively easier than marginal structure model. So the details are in my second paper, appendix. It's too long. But by this method, this is crude incidence. And what happened was this is adjusted. So can you see the difference? So this is as a result of adjustment. So because by adjusted analysis, the model assumes that if the confounding factor is equally distributed between these 8 groups, so it's a kind of simulation that what happens if, for example, the distribution of diabetes or aspirin or smoking status was if equal between 8 groups, what happened? So that 8 groups became closer as a result of adjustment. And now these differences can be ascribed to drug because other factors are completely the same in theory. So these differences are drugs. And then I kind of tested. I mean, this can be test for interaction or effect modification can be done by starter, just by putting sharp mark in the starter model, and this was significant. So now I confidently say that the absolute risk is increased according to the level of kidney function, even after adjusting for confounding factors. Okay. To conclude the second paper, relative risk of SSRIs for GI bleeding was constant at 1.6 to 1.5, 1.8, regardless of kidney function. But excess risk or absolute risk increase was increased as kidney function deteriorated. But my question again, so what? So which should I trust, relative risk or excess risk? Or in the end, can we prescribe antidepressants to patients with CKD or not? And I reviewed previous expert opinions and textbooks. And as far as Rossmann says, if you compare relative risk or excess risk or additive interaction may be more important, named public health interaction, because a larger number of absolute risk increase means a larger number of patients suffering from the GI bleeding due to drug. So excess risk is important for decision making in clinical practice. So he suggests that to focus on excess risk. But what I thought was, if discussing about decision making, my interest was also risk-benefit balance. So coming back to this original question, risk-benefit balance. So if benefit is large, a drug could be used even if risk is high. So you may remember that I split my research question into two, benefit and risk. And I focused on the risk side. And benefit side may be more suitable to be assessed by clinical trial or RCT. And by chance, during my PhD, one big paper, big randomized control trial was published for patients with pre-dialysis CKD, well, I mean, the study, same study population as mine. And there was no significant benefit of antidepressants in this study population, sertraline, discussing that lack of efficacy could be that depression comorbid with chronic kidney disease is a different clinical entity than psychiatric major depressive disorder that is not responsive to medications. So in total, benefit is not increasing, or rather decreasing in patients with CKD. And risk is increasing in patients with lower kidney function. So in terms of both benefit-risk balance, both, it's worse in patients with lower kidney function. So my conclusion was kind of a recent RCT didn't show any benefit. In total, antidepressants may not be recommended in CKD in terms of both risk and benefit balance. Although I should say more research is needed always. Okay, so coming back to be more comprehensive. So I come back to research questions, two questions. So I conducted first paper, drug utilization study, suggesting that antidepressants are more likely prescribed in patients with CKD. But there was a kind of excess risk increased in patients with CKD. And a RCT suggested that benefit was not there. So in terms of risk-benefit balance, probably we should say antidepressants shouldn't be prescribed generally for patients with CKD. So I didn't have any answer 5 years ago, but now if I'm consulted by a junior resident or a psychiatrist, maybe I could advise him or her that generally it's not recommended. So this is almost the end of my presentation. So take-home message. pharmacoepidemiology is fun, but it's maybe easier said than done. And there are a number of branching points you need to make a decision. And if you are worried when making each decision, go back to the basics of epidemiology, like what is prevalence and what do you want to compare. So comparison may be the most important. And follow previous studies or expert opinions. And don't get bogged down or don't spend too much for small difference. Okay, and more details are in these two papers, including appendix and my PhD thesis dissertation, which can be uploaded on website. But if you have any questions or need my assistance, if I can, give me email anytime. So thank you very much.